Thank you for that, Aoife and Diane. It's really nice to get the opportunity to speak to you all today. I do have two small children in the house, so just a bit of a warning just in case they Zoom bomb us all. Okay, I'll start. So really it was my talk was going to give you a bit of a background into the AMS change project that we've done in Manchester. So introducing our project and really giving a bit of an introduction to the concept of behaviour change and how we apply it to antimicrobial stewardship. Now I'm going to go a little bit into exploring how to categorise influences on behaviour and also looking at interventions which we can use to influence behaviours in relation to antimicrobial prescribing. I've also been asked to do a little bit about quality improvement, so I've tagged that onto the end of this presentation, and actually it works quite well in the grand scheme of the presentation as well. I'm really thinking about quality improvement projects and how they can be applied to antimicrobial stewardship. So our AMS change project brought together different professionals from different backgrounds. I've done some work with Diane and the Commonwealth Pharmacist Association in Uganda recently, and taking antimicrobial stewardship to Uganda. And it was great to be able to work with behaviour change experts in this project. And literally these behaviour change experts were up the road from me. And it just seemed silly that, you know, I had to go all the way to Uganda to be able to work on behaviour change, and we haven't done anything locally in Manchester to tackle this. So I got together with Lucy and Joe from the University of Manchester and a few of our colleagues in primary care and also secondary care, really to think about how can we try to tackle behaviour change and how can we bring that into antimicrobial stewardship and our strategy in the hospital. We've been working on antimicrobial stewardship for a long time, and really we feel it's time to do something different and to try something different to try and get people to really think about what we're doing. So a little bit of background about the project. We applied and were successful in getting a Health Education England AMR innovation grant, and that's really, you know, it helped to bring the project together. As I said, we did it in conjunction with some health psychologists, and our main aim was to train a team of master trainers in behaviour change. So we trained 25 healthcare professionals from across Manchester, both primary and secondary care, ranging professions, nurses, pharmacists, microbiologists, surveillance officers, you know, really wide scope. And we trained them as master trainers in behaviour change with the thought that they would then go back into their workplace and take the behaviour change concepts and really try to embed it into their teams, and then, you know, training their teams to become behaviour change champions. And we developed a training package with this. And I've just picked a little bit of this training package to bring to you today as an introduction into behaviour change. So I have got a video to show, and I'm really hoping that it does play. Can you hear it now?
So antimicrobial
Yes.
is a process of trying to use antibiotics as well as possible. So identifying only patients that need antibiotics and prescribing them antibiotics at the narrowest spectrum, so avoiding broad spectrum antibiotics if possible, and using the optimal dose for the shortest duration that is going to be effective. So antimicrobial stewardship will allow us to use antibiotics only when we need to treat an infection, and should therefore stop using antibiotics in patients who don't have an infection. And this will allow us to prolong the life of antibiotics. So I think everyone is responsible for antibiotic stewardship, from the patients through to the prescriber, through to administrators and managers. So from a patient perspective, we need to work with patients to try and reduce the demand for antibiotics, to make it clear that antibiotics are not effective for viral infections and that antibiotics are not a cure-all. Clearly, doctors and pharmacists and prescribers in general need to take responsibility and reduce the amount of antibiotics that are being prescribed. And I think nurses who administer antibiotics, particularly in hospital, can raise issues with patients that they think no longer require antibiotics. So antibiotic resistance is rising, and we've seen in the last 10 years that simple antibiotics like trimethoprim for urinary tract infections are no longer effective. So in Manchester, about 1 in 3 patients have a urinary tract infection which is resistant to trimethoprim, and so we can no longer use this antibiotic. At the other end of the spectrum, we're seeing a rise in multi-drug resistant bacteria. Only a small number at the moment, but year on year, the numbers are increasing. So these are bacteria which are resistant to almost all of the antibiotics that we have to use in the hospital. So antimicrobial stewardship is difficult. It's clear that just telling people to use less antibiotics is not an effective way of introducing antimicrobial stewardship. So hopefully by providing this training, we'll be able to roll out a strategy of implementing antimicrobial stewardship across Manchester, which firstly will directly impact the health and well-being of our patients within Greater Manchester, but also will provide a template which can be used across the UK.
So that was Dr. Tim Felton, who I work really closely with. He's a consultant in intensive care at our hospital, but he's also the chair of our antimicrobial stewardship committee. And it's really great that we have an intensivist and a medic really leading our antimicrobial stewardship strategy at MFT. This next video is the last video, but this is really just to introduce the concept of behaviour change and really, behaviour change, how it applies to health professionals.
As healthcare professionals go about their work, they do or don't do things that will lead to positive or negative outcomes for patients. Healthcare professionals take part in training throughout their careers. Training changes the capability of healthcare professionals. The competence and capability that a healthcare professional has will obviously influence how well they do vital tasks. However, being competent or capable is not the whole story. Evidence suggests that just because someone can do something, it doesn't mean that they will do it. Other than capability, what else do you suppose determines whether a healthcare professional does or does not do a particular task? There are many psychological determinants of practice, and it's helpful to think of these under the umbrella terms opportunity and motivation. Opportunity is physical opportunity, having time and resources, like equipment and other people to help. But it's also social opportunity, believing that other people think that what you are doing is the right thing to do. In this context, motivation is not general energy or enthusiasm. Motivation in this context means motivation about the specific task that the healthcare professional is doing. It can be understood as automatic and reflective. Reflective motivation is a weighing up of pros and cons. For example, will the task lead to better outcomes? Is the task easy or hard? Automatic motivation is being prompted to do something. For example, by your previous behaviours or habits, or by cues in the environment. If attempts to change healthcare professional practice are to be successful, it is crucial to understand what determines behaviours. There is no point having training to increase capability if the healthcare professionals are already capable, but things like opportunity or motivation are getting in their way. The good news is that there are techniques to help people overcome opportunity and motivation barriers, which, if added to training, could make practice change more likely. The Change Exchange is a Manchester implementation science collaboration project hosted by the University of Manchester. This work is funded by grants from the Tropical Health and Education Trust, with the Department for International Development and the Global Health Exchange.
So that just gave you a little bit of insight into capability, opportunity and motivation. So I'm just going to touch a little bit now on specifying behaviours and about how really, if we want people to change what they do, they need to be clear what they need to do. So we're going to work through an example of making behaviour specific, and we will look at specifying who needs to do what, to whom, how, when and where. And as I said, it's really important that people understand what it is we're trying to change, but also, to be clear on what we want the people to do instead. So really, to make this relevant to COVID, we started this project in December last year, and we started to train our master trainers, and with the view that they would go back into their environments and roll this training out. And unfortunately, obviously, COVID hit in March in the UK, so this made it really a bit more difficult to be able to do this training for the members of the team. So we really had to bring it back to basics and think, actually, what we need to redefine the problem. And one of the main problems we have at the moment with COVID is the overprescribing of antibiotics. So we've tried to bring it back and bring behaviour change back to its basics and see how we can apply this to COVID. So one of the things that we really are struggling with is that studies show the rates of bacterial co-infection in our patients with COVID are between 3 and 8%, 8 being really the higher estimate, end of the estimate. It's really around about 3% of patients presenting at hospital. However, and this is true data, an audit that my team conducted locally in Manchester showed that antibiotics are being prescribed for 2/3 of the patients that are admitted with COVID-19 pneumonia. So we need to think about what behaviours we might need to change for this. So we need to really think about the who needs to do what, to who, how, when, and where. So the answer to this is the prescriber is our who, and they need to suspect or confirm a bacterial infection. So that's our what. For patients with suspected or confirmed COVID pneumonia, that's our whom. And how do they do this? They do this by requesting and appropriately interpreting our diagnostics and also our guidelines. And as Diane specified before, documenting their indication and their rationale. And that's our how prior to prescribing antibiotics. So that's our when. And our where is on our COVID-19 cohort wards or in our emergency departments or our admitting units. So that was just really to try and make this behaviour specification relevant to now and our COVID patients. So taking it a little bit further and thinking about our influences and really our influences and trying to match the behaviour to our influences. So we've got psychological capability, physical capability, and they're under our capability umbrella. We've then got our opportunities. So we've got physical opportunity and social opportunity. And then we've got our motivations, so our reflective motivations and our automatic motivations. And those are a list of our behaviours on the other side. So I'll just take in the next slide to the answers to this. And normally we would work through this with our participants, but obviously virtually with such a large group, it's quite difficult to do this. So the answers to this are psychological capability, and our behaviour that matches that is not knowing the guidelines. Our physical capability is potentially not having access to the recommended antibiotics. Our physical opportunity is our member of staff saying, I don't have enough time to talk to the patient about not using antibiotics, therefore I'm going to prescribe them because it's quicker. Our social opportunity is our pressure from our patients or from our patients' carers to prescribe antibiotics. Reflective motivation, and we did see this especially when we did work in Uganda, where their guidelines were potentially a little bit behind the practice, was actually that people didn't agree with the guidelines, so they didn't want to use them. Our automatic motivation, and we see this a lot in our hospital, especially with our consultants, is habitually prescribing what you've always prescribed. So not thinking about it, just saying, I always prescribe this drug for this infection. And it is something that we come across a lot. So how do we explore influences with our with people around us? It's really important when we're thinking about a behaviour and potential barriers that we don't just assume what these influences are. Even if we're looking at people in our own professions, in our own hospitals, we need to try and approach finding out what their influences are with an open mind and try and let this conversation flow. Focus groups are really useful in this sort of situation, and also having individual conversations with people. Focus groups can be really important and really effective, but it's really important to be able to try and engage the individual members of the focus group. You know, we've all been in a meeting or a focus group, or, you know, a session where certain people have taken over, and actually that's really only their influence has come across. It's really important to try and engage with those people who maybe aren't the dominating influences in that room, and really try to explore everyone's opinion and everyone's influences. And trying to summarize and reflect it back, asking, again, open and closed questions, and using a good combination of both. You know, what do you think people need to know if they're going to do this? And what did you need to know before you did this too? What do you need to be able to do this behaviour, and do you think you can do this? Do you need any support? And have you been trained? And really asking them back, do you think you'd remember to do this when you're working? You know, really trying to engage and ask those open questions. Be ready to prompt people for full explanations. So, you know, if somebody dwells on something, you know, ask another open question. That's really interesting. Can you tell me more about that? And again, helping all to contribute. Think about your seating plan, especially if you know there's a few key personalities in that room. So behaviour change communication and gathering information. As we said previously, when we're engaging with people, we're trying to identify their capability, their opportunity, and their motivation for antimicrobial stewardship related behaviours, and really trying to support practice change by using behaviour change techniques. And sometimes we can best influence change through having conversations with individuals about changing what they do. And behaviour science is clear that just telling someone what to do is often ineffective in changing behaviour. Someone is most likely to change if they're aware of their behaviour, if they're motivated to change and make a plan, and they have this plan supported with reminders and prompts. And our conversations with people can really help us identify which of capability, motivation, and opportunity are a problem for an individual. And we can then address these through behaviour change communication techniques. So just briefly touching on developing an intervention. By looking at the intervention on this slide that I went through before about our COVID, can we state which capability, opportunity and motivation are influences on this behaviour, and what types of interventions might be appropriate for each influence? So our capability, our psychological capability, I don't know about. Find out what people don't know about and let them know, inform them, give them the materials, arrange training, talks, emails. If it's a physical capability, I don't know how to, or I can't. Again, find out what people don't know and hold a skills-based training session. Our physical opportunity, I don't have enough time to do that, can be due to feeling overwhelmed or something that actually the person you're talking to doesn't think it's a priority. So we need to show empathy. Does this new behaviour take time? Actually, if we're doing this new behaviour, will it reduce time in the future? And can we build this into our work plan? Our social opportunity is really thinking about our patients and our colleagues would hate it if I did that. Why do you think people don't approve of what you're going to do? And what do you think that they can do about that? And how can we support them through that? So really, I'm just taking you back to specifying your behaviours. And this is really one of the fundamental elements of behaviour change. And like I said, this is really an introduction to behaviour change and stewardship. So really try and think about, what are you going to do? How are you going to do it? When and where? And apply that to what you're trying to change. So moving on to quality improvement. Now, when Diane asked me to include quality improvement, I thought, oh, I'm not a quality improvement expert. And actually, none of us are, but it's something that we all do, and it is embedded into our work in the NHS. And when we're trying to plan an improvement or change working process, it's essential to try and know what you want to achieve and how you'll measure it, and really be explicit about what you want to be tested. It's also important to acknowledge you might not get the results that you expected, and it's safer and effective and more effective to try and test out it in a smaller environment or on a smaller scale before implementing these big changes across the board. The key questions we need to ask in a quality improvement project are: what are we trying to accomplish? How will we know if our change is an improvement? What measures of success will we use? What changes can we make that will result in improvement, and how are we going to improve that and prove that? Sorry. So this takes you to the a PDSA cycle. Okay, so the 4 stages of a PDSA cycle are plan. So that's thinking about the change to be tested or implemented. Do, so carry out the test or the change. Study it. Think about your measurable outcomes, collect data before and after, and reflect on this. And then act. So what are we going to do? What changes are we going to implement from this? And also, are we then going to move into another PDSA cycle? What are we trying to accomplish? It's really important to think about this at all stages. We need to set clear and focused goals with measurable targets. And it's really important that we have clinical leadership. Trying to make any changes in healthcare is difficult enough, but if you don't have the clinical leadership behind it, then it's going to fail when you try to enact changes. We need to focus on problems that cause us concern, as well as on our patients and our staff. And these problems should be relevant to the length of the project. Be bold in your aspirations, but acknowledge that maybe you might need to do several different PDSA cycles in order to accomplish everything that you're trying to accomplish. How do we know if the change is an improvement? We need to measure outcomes such as improvement in our guideline compliance or reduction in broad spectrum antimicrobial consumption. And if we make a change, can we demonstrate over time whether the change has led to a sustainable improvement, or was this just a smaller change in an area that actually the next year we go back and actually practice has gone back to what it was? We can have PDSA cycles starting, so we complete a PDSA cycle and then we move into the next one, and that's our diagram on the top, that our act is actually to start a new PDSA cycle and start a new route. We can also have PDSA cycles going on at the same time, so really occurring together, so different people in different areas are carrying these out and we're bringing the projects together. So there's a lot of different complexities around how you can carry out your PDSA cycle. Now, this is how I often feel when someone presents me with a new piece of information or a new framework. When will I ever use that? And actually, this person had no idea how it works in the real world. Is this actually something I can use? And actually, with PDSA cycles and quality improvement projects, it is. They are simple, and really it's giving you a structure to base your changes on. So I'm going to take you through a PDSA cycle that we have done at work and we have applied to antimicrobial use. So one of the problems, we have a large respiratory cohort in Manchester. We have one of our sites has a number of respiratory consultants who anecdotally we didn't feel were potentially using the antimicrobial guidelines as they should be. We've tried different ways to get into the team and really to get onto the ward, but we've always been presented, you know, it's been a bit of a hands-off. No, it's fine, we're fine. So one of the respiratory consultants did a quality improvement training, and she came to us with her own PDSA cycle, which was great because actually she identified an area in respiratory she wanted to focus on, and she wanted our help and input. But she didn't want us to do it, which was great because we could support from the sidelines and really, you know, see how she went. And we've been able to then show this to other areas in our hospital as a good example of how actually we can embed quality improvement, but you don't necessarily need it led by one of the antimicrobial stewardship team. So the plan was to review the prescribing of antibiotics in community-acquired pneumonia. The standards they used were our antimicrobial guidelines and also the British Thoracic Society guidelines. The WHO, so they audited all patients admitted to 2 respiratory wards over 3 months. The data was collected by the respiratory team and they had clear objectives and expectations, which was great to see. I learned a lot from just watching them do this. So the audit was carried out as planned. We had regular meetings with the team and everyone in the team was held to.
So I'll take you back to the act. So at the end, we thought, what now? And we thought, did we bite off more than we could chew? And potentially we did. It was quite a big project. The team fed back to the key stakeholders. And again, you know, they together developed an action plan. And this was really important to engage the key stakeholders in this and think with them, what now? What were they going to take away and do? Did we need some guideline change? And did we need a further PDSA cycle to start? So I just thought it was useful to take you through a PDSA cycle that really was applied to antimicrobial stewardship and see how it worked in our area. Taking you through a bit of a whistle-stop tour of behaviour change and antimicrobial stewardship, which I hope you found useful. And thank you very much for inviting me to talk to you today.
Cool. So Fran, I've got a question for you. So when you first got into behaviour change, did you think it was too complicated? And how did you navigate it to becoming actually, it's not as bad as it looks when you first start? Obviously, it's a whole profession in terms of health psychology. But actually, when we bring it down to the basics of what we need to do as individuals, as doctors, as nurses, and as pharmacists, how have you been able to navigate and just bring that together?
So you're right. Initially, I was quite apprehensive and quite overwhelmed by what I thought behaviour change meant. And actually, when you reflect on it, it is things that you're doing all of the time, you know, especially as pharmacists. You know, it's our job to often try to influence people, you know, to change their behaviours or to change that prescription or to prescribe less antibiotics. And really what I felt was it was a tool to really coach me into how to do that and to have those questions, you know, to have those conversations. And really, especially because I was doing the fellowship at the same time, I felt I was able to bring leadership elements into it and, you know, see the overall rather than thinking this is huge, you know, people have spent years of their life training in this. It was to try and break it into small chunks and how can we apply this to different situations. And I think bringing it back to capability, opportunity and motivation is a really important thing to do because it really makes it seem less big and, yeah, an easier problem to think about.